Bismillah ar-Rahman ar-Rahim. Welcome in the first ESNT online CMA meetings after Ramadan and Eid. كل سنة وحضراتكم طيبين. We are honored today by having our great Professor Muhammad Subh as a moderator of this meeting and the head of the Egyptian Society of Nephrology and Transplantation, Professor May, as the speaker in this very special meeting of Egyptian Society of Nephrology and Transplantation online meetings. I would like to thank first and welcome our Professor Muhammad Subh for being with us today. Professor Muhammad Subh is, of course, is well known for all to us and is all known all over the world and Africa and the Arabic world. He is the professor of nephrology and internal medicine in Mansoura University. He is Mansoura Nephrology and Urology Center and the winner of my prize of medicine. I would like to welcome him and thank him really for his continuous support for this platform by responding to all our requests to moderate our meetings and to be with us and share his experience and his marvelous experience over all our meetings. I would like to thank him and welcome him again and welcome Professor Mai, who will be introduced by Professor Subh in this special talk about the liver-kidney interactions. So I will leave the floor to Professor Subh to lead this meeting and welcome him again. Please Professor Subh, thank you and welcome. Professor Subh, can you hear me?
Can call him?
He is unmuted. I think he is unmuted. He is offline now.
I think you should call him. Yes.
Sorry for this technical difficulty which occurred now, but okay, I'm going to say first, I would like, by the name of all my colleagues, I would like to thank, of course, Dr. Yasser Abdel Hamid, Professor of Nephrology, Qasr Aini, Cairo University, for his continuous effort giving us this very interesting, very fruitful meeting.
Thank you, sir. Thank you.
Also, I will express my honor, my happiness for having this chance to introduce Dr. May Hassaballa, the head of our society, of Egyptian Society of Nephrology, and one of the best professors of nephrology in Egypt now. Always she presents to us very interesting talks, updated lectures, and as usual, we expect this lecture will be very fruitful for all of us. Please, Dr. May, please start talking.
Thank you very much, Professor Muhammad, for the introduction. And of course, it's an honor to me that you are moderating this talk. Liver-kidney crosstalks is our topic today, and I'm really always fond of crosstalks. It's really amazing. Okay, ثانية واحدة أكبر بس. So it's really amazing how the body organs, they interact together by crosstalks all the time in health and disease. And this occurs through cytokines and other mediators, also through hormonal, neuronal, metabolic, and other mechanisms. And you will notice that the crosstalks are not only occurring between the liver and kidney, but it's also all the body systems are involved, actually. So the agenda today, we're going to speak about the liver-kidney crosstalks, and we'll concentrate on hepatorenal syndrome type 1. And we'll speak about kidney-liver crosstalks, and then we'll talk about the combination of liver disease and renal dysfunction, and we'll give examples of viral hepatitis and non-alcoholic steatohepatitis, which is the NASH. So for the liver first, you know that when you have advanced liver cirrhosis and portal hypertension, you get increase in gut permeability, and bacterial translocation. And this is going to result in systemic inflammation and release of cytokines. And then there's going to be a severe splanchnic arterial vasodilatation that will reduce the effective arterial volume. So the cardiac output will increase at first, but will not be sufficient to raise the plasma volume or normalize the arterial effective volume. So there's going to be activation of the sodium retaining and vasoconstrictor systems. And this is going to result in salt and water retention, kidney vasoconstriction, and renal function impairment. And this is what we mean by hepatorenal syndrome, AKI. So the main thing is the circulatory abnormalities that occurred with marked splanchnic arterial vasodilatation as the first step, which is followed by activation of the intrinsic vasoconstrictor systems in the body and vasoconstriction, kidney vasoconstriction, and reduction of the GFR. But you will also notice that the most important actually is the existing systemic inflammation, which is occurring in liver cirrhosis. And so the new theory of development of complications is that when you have cirrhosis, you get portal hypertension. As we mentioned, there's going to be bacterial translocation, and we have what we call pathogen-associated molecular patterns. Also, when you have liver injury, you get damaged cells and you get damage-associated molecular patterns. And these have receptors, recognition receptors, that are going to release pro-inflammatory molecules, including reactive oxygen species and reactive nitrogen species. And this is going to result in splanchnic arteriolar vasodilatation, which is marked. As you mentioned, there's first going to be increase in the cardiac output, but then there's going to be cardiovascular dysfunction. We can have what is called a cirrhotic cardiomyopathy, where you have diminished contraction in response to stressful stimuli and impaired diastolic relaxation, electrophysiologic changes in a patient who had not previous cardiovascular disease before. So all this is going to result in kidney dysfunction, as well as hepatic encephalopathy and hepatopulmonary syndromes, and you get this crosstalks with all other systems. And you also have adrenal dysfunction, and that's because of depletion of cholesterol, which is the main substrate for steroids. Pro-inflammatory cytokines, they suppress the hypothalamic pituitary adrenal axis, and glucocorticoid resistance, they will not be able to down-regulate the transcription of inflammatory cytokines. So you will have a perpetuation of the whole thing. Now, this is a very interesting paper on hepatorenal syndrome type 1, which was issued in February 2022. And it's very important because it tells you how to diagnose AKI in cirrhosis, because not AKI is a hepatorenal syndrome type 1. Of course, there are AKIs that are commonly occurring in liver patients, like the hepatorenal syndrome type 1 that we're speaking of, and the pre-renal azotemia, and acute tubular injury or acute tubular necrosis. So these are the conventional factors that we commonly see in liver cirrhosis patients. But you can also have as well abdominal compartmental syndrome due to marked massive ascites. You can have cardiorenal syndrome type 1. You can also have acute glomerulonephritis, acute interstitial nephritis, and obstructive uropathy. Mind you also that you can have more than one factor together, and you can even have an acute kidney injury occurring on top of a CKD. So diagnosis is very important, and how to diagnose hepatorenal syndrome, this kind of hepatorenal syndromes. Hepatorenal syndromes, as the first definition was previously classified based on the acuity of renal function deterioration, as hepatorenal syndrome type 1 is a doubling of serum creatinine above 2.5 milligram per deciliter within 2 weeks. And hepatorenal syndrome type 2 is a slower increase in serum creatinine to a value of more than 1.5 milligram per deciliter. So now the type 1 is now called hepatorenal syndrome AKI, and the type 2 is called hepatorenal syndrome CKD. But it's also very important to differentiate between the hepatorenal syndrome AKI and other AKIs which are not hepatorenal. So the latest guidelines of the International Ascites Club revealed that the definition of AKI in this population has changed based on the KDIGO guidelines, because they have changed, they removed the cutoff values of serum creatinine. So when do you diagnose hepatorenal syndrome AKI? If you have a patient with cirrhosis and ascites with increase in the serum creatinine of more than 0.3 milligram per deciliter or more than 1.5 times the baseline creatinine, or a 50% increase within 48 hours from the baseline, with no improvement in creatinine after 2 days of stopping diuretics or giving volume expansion with albumin, and in the absence of shocks, you are excluding other possible causes, in the absence of regular or recent consumption of nephrotoxic drugs, and in the absence of signs that denote injury of the renal parenchyma, like proteinuria more than 500 milligrams per day, hematuria more than 50 erythrocytes per field, and or abnormal renal ultrasound. So this is a functional and a reversible. Of course, it's a diagnosis by exclusion, as you can see, but it is functional and reversible, and the main cure is by doing liver transplantation. Why is it important to differentiate among the causes? Of course, you can see that pre-renal azotemia can occur commonly in those patients because you give them laxatives and you have GIT losses. So in this case, the treatment is going to be albumin plus minus intravenous fluids. Acute tubular injury can occur due to gastrointestinal bleeding causing ischemia, or toxic due to bile. And in this case, the treatment is going to be supportive care. Acute abdominal compartmental syndrome due to tense ascites, treatment is going to be a large volume paracentesis. Cardiorenal syndrome type 1 can occur with, like in cirrhotic cardiomyopathy. So the treatment here is going to be diuretics plus minus inotropes. Acute interstitial nephritis can occur because these patients are commonly given quinolones, like in spontaneous bacterial peritonitis. So the treatment here is going to be to stop the drug and maybe give corticosteroids. Acute glomerulonephritis can occur, like in cases with hepatitis C, for instance, and here the treatment is going to be immunosuppressive medications. So these are completely different medications when you compare it to hepatorenal syndrome type 1, where the unique treatment is going to be vasoconstrictor therapy. Because in normal circumstances, you have a maintenance of the renal blood flow through the renal autoregulation at different mean arterial pressures, whereas if you have liver cirrhosis and splanchnic vasodilatation, there's going to be stimulation of the baroreceptors that are going to activate the sympathetic nervous system, renal angiotensin system, and there's going to be loss of the renal autoregulation and reduction in the renal blood flow. Whereas if you give vasoconstrictors, you're going to improve the mean arterial blood pressure, and you will reset the baroreceptors and reverse the whole process, and we get improvement in the renal blood flow. So therefore, treatment in this condition is mainly through vasoconstrictors. You have amidodrine, octreotides, and in the hospital setting, you can use terlipressin, which is a vasopressin analog, and norepinephrine can also be used. There are other emerging therapies, like, for instance, the serelaxin, which is a recombinant human relaxin, and is found to improve the renal vasculature. Actually, experiments have been made only in animals so far. Pentoxifylline is a phosphodiesterase inhibitor, and it was found that when combined with the vasoconstrictors, it produces better results. And of course, when you combine albumin with these vasoconstrictors, you also get a better result. So what do you do for prophylaxis? You have to promptly control the spontaneous bacterial peritonitis. Rifaximin is one of the very good antibiotics. And when you do large volume paracentesis, you supplement with albumin, 6 to 8 grams per liter of acidic fluid removed. And when you use diuretics, you avoid body losses exceeding 0.5 grams per day in patients without peripheral edema, and not exceeding 1 kilogram per day in the presence of peripheral edema. And when you use spironolactone, don't exceed 400 per day. And when you use furosemide, don't exceed 160 milligrams in divided doses. So now we move on to the kidney renal crosstalks. So when you have acute kidney injury due to the very variable causes that you know of, you get the normal physiologic changes that we see, the volume overload, the uremia, hyperkalemia, metabolic acidosis will all occur. But also we have systemic inflammation, which is very important, and even immune dysfunctions. So when you get volume overload, you can have hepatic congestion, which can occur directly or through the occurrence of hepatorenal syndrome type 3 or renal hepatic syndrome. And uremic toxins can affect the cytochrome P450 as well as the metabolic acidosis and inflammatory markers. And of course, you know that the cytochrome P450 is mainly present in the liver cells, and it is responsible for the metabolism of more than 75% of the drugs. You will notice that many anti-cancer drugs have impaired metabolism. They are mainly metabolized by the liver, but they have an impairment in metabolism when in the presence of renal impairment. Metabolic acidosis can also stimulate gluconeogenesis and can also cause increasing the rate of systemic protein turnover. And systemic inflammation, you have interleukin 6 upregulates C-reactive protein and serum amyloid A and TNF alpha, as well as interleukin 10. They also play an important role in the suppression of the cytochrome P450. Interleukin 17A is also very important as a mechanism in the renal, in the kidney liver crosstalks. It also increases the oxidative injury, which is related to or correlated with the hepatocyte leukocytic infiltrations. So when you have, I just want to mind you that relationships which are outlined in gray are primarily extrapolated from in vitro or animal data. So you can have also, when you have kidney dysfunctions, you can have immune dysfunctions because you will get increased production of cytokines as well as decreased clearance. And you will also have impairment in neutrophilic functions. And when you have as well liver dysfunctions, you will also have more immune dysfunctions, and the patient is going to be more susceptible to infections because there's going to be as well impairment in the complement synthesis, and there's going to be defective phagocytic function. So when you have acute kidney injury, you don't really get acute hepatic decompensation, but you get subtle but significant changes that can occur, like increase in vascular permeability, like altered cytokine profile, increased oxidants, decreased antioxidants, increased serum bilirubin transaminases, altered lipid metabolism, altered protein metabolism, and altered hepatic drug metabolism. Now we looked at the condition where you have an underlying illness like sepsis, ischemia, inflammation that can affect both together. So this is going to result in an inflammatory state that is going to even perpetuate the inflammation to other distant organs as well. So when you have a combination liver kidney disease, maybe due to what we mentioned now, that hepatorenal syndrome or pre-renal AKI due to sepsis, ischemia, and inflammation, but we can also have non-pre-renal, non-hepatorenal syndrome, such as occurs in the NASH and viral hepatitis. And we'll give you an example of hepatitis C virus, for instance. And this slide is one of Professor Rashad's. So when you have hepatitis C virus, you have the antigen and the antibody that can result in immune complexes that cause the occurrence of cryoglobulins, vasculitis, acute kidney injury, as well as glomerulonephritis. Or you can have the antibodies directed to the infected hepatic cell or other altered cells, and this is going to cause autoimmunity. Again, can cause glomerulonephritis, hepatic fibrosis, or hepatocellular failure, or you can have a direct cytotoxicity with accelerated progression, resulting in increased cardiovascular events as well. So when you have HCV, you can have type 2 mixed cryoglobulinemia, resulting in type 1 MPGN. Or you can have antigen-antibody complex, and this can cause, again, type 1 MPGN or polyarthritis nodosa, membranous nephropathy, or IgA nephropathy. Or you can have direct tissue infection, which can result in FSGS. Of course, you all know that hepatitis C is an important determinant, independent factor in mortality for patients in dialysis, because when you have HCV infection, again, you get replication within the plaques, again, pro-inflammatory cytokines, cryoglobulins, insulin resistance, steatosis, Oxidative stress, again, will all cause a chronic local and systemic inflammation that will not only affect the kidney, but also the cardiovascular system. Now we move to NASH. And but the pathophysiology of NASH is that when you have genetic and environmental factors like diet or obesity, you get a gain in the adipose tissue. And this is going to result in a chronic low-grade inflammation. There's going to be a mobilization of free fatty acids that is going to be in the visceral deposition and ectopic deposition. In the liver, we'll have steatosis that is going to result in lipotoxicity and increased oxygen oxidative stress. And this itself is going to result in mitochondrial dysfunction, hepatocyte apoptosis, hepatic inflammations, all stimulate the pro-fibrotic elements, resulting in fibrosis. If you add to this a failure in regeneration, you're going to end up with liver dysfunction. So the existence or the continuation of the altered lipid metabolism and the oxidative stress together with the inflammatory cytokines is going to result in progression of NASH. So therefore, NAFLD or non-alcoholic fatty liver disease and CKD is going to cause acute kidney renal failure, or CKD. Acute kidney failure occurs when you have hypovolemia with stimulation of the vasoconstrictors, and this hypovolemia is going to result in affection of the kidney, vasoconstriction, increased creatinine, and increased proteinuria. And actually, this is it is a mechanism that's going to and fro. It's a vicious circle. So when you have NAFLD, you get insulin resistance, steatosis, necroinflammation, fibrosis, and this is going to result in increasing in inflammatory cytokines, increased interleukin-6 activated protein kinase, decreased fat to increase uric acid synthesis, and then the kidney will have the activation of the RAS endothelial dysfunction. It will end in glomerulosclerosis, tubular interstitial fibrosis, and this is going to result in increased adiponectin, adipose tissue inflammation, and so on and so forth. So we're going to get into a vicious circle. This occurs in 10 to 15% of the general population and occurs in 20 to 50% in patients with NAFLD. Now, if you look at the compare the healthy controls with the patients with non-alcoholic steatohepatitis, you can compare the abnormal albuminuria, which is definitely more increased in the NASH patients, as well as CKD and different stages of CKD. But I'd like to draw attention, and this slide I got from Professor Abdelkhaliq Hamid, that in almost 30,000 subjects enrolled in this study, NAFLD per se was not a risk factor for CKD, but NAFLD patients with advanced cirrhosis face a higher possibility of CKD, and therefore those patients with NAFLD and advanced cirrhosis should be screened for CKD. And other longitudinal observations that also emphasize the importance of advanced fibrosis as a determinant of NAFLD outcome. So I'd like to end with the verse from the Quran, وَفِي أَنفُسِكُمْ أَفَلَا تُبْصِرُونَ, and in yourself do you not see? And of course, it's really amazing things that are happening not only around us, but also inside us, and we're not aware of. And thank you very much. Thank you.
Excellent. Tramay, as usual, very interesting, full of sharp edge of knowledge, data.
Thank you, thank you.
Okay, very much. Okay, so we can now, Dr. Yasser.
Yes. Yes, thank you, Professor May, for this very comprehensive and to the point lecture. I can go to the chat. We have some comments and questions from Dr. Abdelhamid Hamdi Ramadan, asking about some new data about SGLT2 inhibitors as cites as it is minimally affects intravascular volume. He's asking about the effect of SGLT2 inhibitor about the intravascular volume and the effect on the liver. Is there a relation between this, or?
Well, it can produce some vasoconstriction, and if you speak about the uricid that's going to occur, but this can be compensated for, and it does cause a little bit increase in serum creatinine at the beginning, but then it resolves with time. So its after effect is much better than its preliminary brief effect.
But I think after you finish, Dr. Mari. Using this new group of drugs, I think in a critical setting.
Yes. Not in a critical setting. No, not in a patient with cirrhosis. No.
We may induce acute kidney injury by this drug.
No.
Yeah.
You don't use it. You don't use it in any patient with any critical situation at all. It has to be a stable patient and with no problems, with no predisposing factors like UTIs or amputations or things like that, and not in a hospital situation, not having any problem like sepsis or anything that indicates his hospitalization. So it's not a drug to be started in hospital even. It has to be in a stable patient.
Yeah, stable. These patients are potentially their effective circulating volume are decreasing. So giving these drugs in a patient like this can.
And I'm I did not understand from the question if it is if he is asking about use of this drug in this particular patient with liver cirrhosis. Of course not.
No, of course. Yeah, I quite agree with you.
Yes, of course not. Not in any critical situation. This is a liver cirrhosis patient already having defective in the intravascular volume. So not to be used and not in any critical situation.
Also, I have a good point regarding this patient. If we have a patient with hepatorenal, liable for hepatorenal syndrome, a cirrhotic patient receiving a hypotensive drug. Usually we give hypotensive drugs and follow up on regular basis. Sometimes cirrhosis can cure hypertension by this peripheral vasodilatation and splenectomy vasodilatation. So you are giving hypotensive drug and you forget about it, but their effect will be augmented and patient can go into hypotension, which by itself can precipitate acute kidney injury in cirrhotic patient.
Exactly.
So giving hypotensive drug in a cirrhotic patient, we have to do regular follow-up looking for this blood pressure.
Yes.
Especially,
expect it to go down, of course.
Yeah, especially usually we give beta blocker to prevent rupture versus and these things.
Yes, right.
Even this beta blocker can precipitate acute kidney injury and a hepatorenal syndrome-like condition. Yeah.
So you have to keep an eye on the blood pressure, definitely.
Yeah.
And this patient is also receiving diuretics and beta blockers.
Yeah, excuse me to ask if there is any recommendation to follow liver functions while giving SGLT2 inhibitors apart from causing hypertension if they are normally given in the usual situations and no effect on blood pressure or no effect on hypovolemia. Is there a recommendation to regular monitor liver functions?
Because you're using in a liver cirrhosis patient, and we're not going to use it in a liver cirrhosis patient.
Even in child A?
No, you can use it if it is a compensated liver. You can use it if it's a compensated, but there is no, not to my knowledge that it is recommended to follow up the liver function in particular. So you're following the liver function
because
I think if you balance benefit and risk, always cirrhotic patient when he is acidic, he is hypovolemic, and if he's not hypovolemic now, at any time he could be hypovolemic due to either hypoalbuminemia and the progressive increase of his ascites, or if I'm going to give diuretic, I think the risk of giving ACE in a patient like this outweigh any possible benefit. So I will not give ACE and ARB in a patient with cirrhosis and ascites unless there is a very strong indication, such as heart failure or something like this.
Mm-hmm.
Yeah.
Yes, and this is the completion of the question with Dr. Abdel Hamid. He completed his question about, he's asking about, because it is given in acute heart failure, which may be complicated by cardio, renal, for example. This is your point, Professor Subh, was the continuity of Dr. Abdel Hamid question, that the situation in case of acute heart failure also with cirrhosis and cardiorenal syndrome.
Yeah.
طبعا you are using drugs that are double weapons, so whenever you use these drugs, you know there are complications and you will have to follow up your patients properly. يعني لو واحد liver cirrhosis وcompensated وحلو، احنا بنfollow up عادي وبنشوف and we find out what's happening. We have to keep an eye on those patients all the time. السؤال بقى معلش يا ياسر بتاع الهارت فيلير كان related to heart failure. ما هو لو في indication.
The same question is asking about even approved in acute heart failure, which may be complicated by cardiorenal. He is asking, as Professor Subh said, that in a situation we must use in case of acute heart failure, for example, complicated by cardiac cirrhosis,
Yes.
or and renal.
So you will always have to weigh things. How bad is it needed for the heart, and how bad is the liver, and so you will always have to weigh your patients what drugs to use. If the cardiac condition is necessitates its use, and you will have to use it, and you follow up with care. These are the types of patients who have multisystemic dysfunctions, and of course these are problematic cases, and you will have to take care of all the drugs you are using.
Dr. Tariq Tantawi.
Thank you, Tariq.
السلام عليكم، كل سنة طيبة وكل سنة طيبين. بروفيسور معي، بروفيسور صبح، بروفيسور ياسر. Many thanks a lot for your fruitful presentations that open an idea about the pathophysiology of hepatorenal and liver and kidney crosstalk. But actually, what we have still treatment is lagging to the point, especially in this dramatic situations. And for that, how we raise an option about the anti-inflammatory, as you mentioned, the alteration in the liver or the kidney, not only for the kidney is not only hemodynamic, and we have profound inflammations. Is there any role for anti-inflammatory or anti-immunosuppressive that will alter the progression of inflammation, or not yet? And we have a need for more researches to improve our management in that dramatic scenarios. What's your opinions, Professor Subh and Professor Mai?
I think we still need a lot of research to find out. And what we are using now, or the two latest drugs that are being tried now, is as you mentioned, the phosphodiesterase inhibitors, but still very little studies in humans, and not still to be included in the guidelines. And definitely we need more research. Professor Subh, حضرتك
To my mind, the anti-inflammatory, either you mean, for example, non-steroidal or corticosteroids, or immunosuppressive drugs. I think these drugs, their risk outweigh any theoretical benefit. So no, we are just trying to reverse the hemodynamic, such as hypoalbuminemia, and decrease the oncotic volume or oncotic pressure by giving albumin, IV albumin. We can give it in a dose of 1 gram per kg, maximum 100 milligram daily to increase serum albumin and consequently the oncotic force, keeping the vascular volume. To give drugs such as Dr. May said, the Melodrine. And by the way, the dose given is much more than we give. Yes. Usually we recommended 15 milligram, up to 15 milligrams 3 times daily to increase the blood pressure, to induce vasoconstriction. Also, octreotide, which causes pernicious vasoconstriction. All these, we are trying to raise the blood pressure, to increase the oncotic force, consequently to improve the renal hemodynamic. This is all what is available currently for managing a situation like this, hepatorenal syndrome.
I think the regular immunosuppressive medications in those patients are very much liable to infection.
Yeah.
Will not have place here.
Yes.
So we're looking for something that is to be a new thing, a new drug to come out. We still don't have that actually.
Question from Dr. Ahmed Mabrouk Sheikh about the transplantation. Thanks a lot, Professor, for this fruitful lecture. Regarding hepatorenal syndrome, can we diagnose hepatorenal syndrome in a renal transplant case? I have a case of advanced liver cirrhosis presented with thrombocytopenia and low serum albumin and dense ascites and anuria. How can I manage immunosuppression as MMF in the view of decreased platelets and TAC induced TAC in the view of anuria? Can take a renal biopsy as the patient is thrombocytopenic.
So this is a renal transplant patient who developed liver cirrhosis post-transplant? And this is an advanced kind of cirrhosis with ascites and thrombocytopenia and.
I can, Dr. Ahmed. Ahmed Mabrouk Sheikh. Can you present shortly your case, please, Dr. Ahmed? Unmute yourself.
So you have to.
Yes, hello.
You have a patient who is.
I have a patient, yes, renal transplantation case, and presented with completely advanced liver cirrhosis. All of a sudden, patient didn't know that he is a cirrhotic. We did an ultrasound as a routine, but we pre-biopsy to preparing for a renal biopsy, we suddenly discovered he is a liver cirrhosis with a platelet is around 20 and serum albumin is 2.7. The original disease is polycystic kidney disease. And we did tapping for the ascites. It was hemorrhagic. So it's, I am very confused about this patient. He is under my supervision right now, so I'm very confused with him.
And how about his kidney functions? He
is totally anuric, and he received
totally
a 4 session.
Yes,
unfortunately he received 4 hemodialysis sessions till now, and he is on Melodrine, Glipressin, and albumin. He presented shocked. He was shocked on levo around 12, and now he is off levo. But I don't have a plan for him. I am shocked also.
Yeah, I think we are looking for patient survival now.
Yes.
Yes.
And by the way,
your plan is to keep your patient alive.
He is young. He is young age, and he is a doctor also. Yeah, and he's not a young age. He is around 45, and he is a doctor. So I am.
In patients with advanced cirrhosis, by the way, it is difficult to have a kidney interjection. Usually the patient is immune suppressed.
Yes.
And I think in this patient, for example, you have to remove the calcineurin atom, since it is nephrotoxic and hepatotoxic. Yes. And you take your MMF to minimal. By the way, you can stop even antiproliferative and just to give steroid in higher dose. In this patient, I think you are looking for patient life. He has no chance for his kidney, and possibly also he has
his liver. I think he's going to need a kidney liver transplantation if he makes it.
Kidney and liver transplantation. There is no hope for this kidney. and no, and I am seeking. I want to يعني أتجنب renal biopsy.
No
Yes,
for kidney biopsy.
Renal
Ahmed.
biopsy, yes, yes.
with
No
the
for
platelets,
kidney
too
biopsy.
risky, very
No
risky.
for rejection.
Avoid, yes, to
anti-rejection
avoid renal
treatment.
biopsy. Okay.
No anti-rejection, no biopsy. You just supportive treatment
yes.
for this patient.
I discontinue with the I discontinued the MMF and tech, and I start
Campylorine as well.
and yes, I did.
Yes.
That's what I did. And
So-
I increased the I started Solimedrone empirical, just يعني that's what I did.
No.
Don't give big doses of Solimedrone.
Yeah.
Yes.
And
Mini
and,
pulse,
and
just a mini
like,
pulse.
like
I did it
Professor
200.
Subhi said, it's the life of the patient that you're caring for now, not the kidney. It's the life of the patient that you're caring for. And if you stop all immunosuppressive medications, and if God wills, and the patient is too weak to reject, the kidney will continue. But what's
I hope.
important now is that you take care of the life of the patient first.
Okay. Thanks, Dr.
Steroid only, Ahmed. You are giving steroid for his suprarenal. He has suprarenal failure. So you give also only steroid for a patient like this as a supportive treatment.
Yes.
But of course, you give albumin, you give vasopressor, you may give antibiotic, anti-ulcer measures should be given, stress ulcer and these things. But kidney, forget about this kidney.
Okay.
Yeah.
Okay. Thanks, Dr. Subhan. Thank you, Dr. May.
Another question from Dr. Abdullah. From Dr. Abdullah, who asking about the role of rifaximin as primary prevention of hepatorenal syndrome.
Oh, yeah. دكتورة ماي please.
تفضل ترسف تفضل.
يا تفضل حضرتك.
لا تفضل هو انا عارف احنا بنجيب لما يكون في spontaneous bacterial peritonitis.
هو sometimes they give it as prophylaxis. Then locally acting quinolones, it is given as maintenance dose to prevent spontaneous bacterial peritonitis.
ده في الحالات اللي بيبقى فيها repeated spontaneous.
I see. When the patient is at risk of spontaneous, you can give him as maintenance dose. I think there is a work which compared those receiving and versus those not receiving this drug. They found that spontaneous bacterial peritonitis are less on those receiving this local acting quinolone. But it has not to be given at large for all cirrhotic acidic.
Yes.
But as Dr. Amay say, those who are liable for spontaneous, you can put them on maintenance. Oh, yeah.
So you are using for spontaneous bacterial peritonitis, not for hepatorenal syndrome. Prophylaxis of bacterial peritonitis.
Spontaneous as a precipitating factor for hepatorenal.
Yes.
Oh, yeah.
Okay. Another question. Huh? Sorry? Another question from the chat from Dr. Abdelhamid Hamdi. He's asking about two questions about the using measuring intra-abdominal pressure in patient with ascites to decide for tapping or only with massive ascites, asking upon the depending on measurement of intra-abdominal pressure to decide tapping or not, and the use of chronic PPI in liver disease can predispose to CKD, chronic kidney disease, or only in some genetic patients, or there is a risk for all the population.
طيب انت الميجرمنت اوف انترا ابدومينال بريشر انت رد على السؤال ده بقى ياسر ده شغلك يعني.
I think بعد اذن حضرتك دكتور صبحي I think
اتفضل يا باشا.
measurement of intra-abdominal pressure is mainly related to the presence of acute kidney injury, compartmental syndrome, not to decide the tapping of ascites or not. Tapping of ascites is related mainly symptomatic, massive ascites related to symptoms, but measurement of intra-abdominal pressure, as far as I know, there is no recommendations to measure to decide for tapping or not. Only in cases of severe abdominal distension to decide for if there is a compartmental syndrome or not. Yes. And the second question regarding PPI,
I think so these patients are also liable to gastritis and stress-related and such things. Of course, you still need to use these drugs. They're liable to ulcers also. How long to give? If you mean that you're going to give forever, you try to reduce as much as you can. For instance, if you give it 40 milligrams, you can give it for 3 months safely, no problem. But the problem is when you continue the duration of these drugs. So you can try to reduce the dose and see what happens. So you manipulate. You can try make it 20 milligrams. You can try and make it every other day, and you look at the symptoms. So it will have to be by trial and error after that. But again, not every patient is like the other, and you will have to find out. Some patients you will continue giving the drug. Of course, if you do an upper endoscopy, it will also help you to know if this is functional or actual gastritis or otherwise. Some patients, they tell you, whenever I leave the drug, I feel horrible. I cannot leave it. I have to take it every day. So you may need to do an upper endoscopy to find out what's really happening, because you can give it only as long as it is needed when indicated. But if the patient has no problem, which apart from varices, of course, then you don't have to continue on it. So you try to use it as little as you can. To shorten the duration as much as you can, and try to find out what's really happening if you find out that you need to continue for longer periods.
And I think one of the most drugs to stop in our community is the PPI that we usually face in our everyday work.
Yes, because everybody who receives PPI will continue to take it forever, which is completely wrong, of course. It is a predisposing factor, not only for kidney affection, also for cardiac and other drugs and other, diseases, many diseases actually. So.
A term Dr. May said, very nice notion, statement. The patient will say to you, when I stop drug, I suffer. So usually we tell the patient, try not to take this drug continuously or daily. When you feel you need it, take it. When you can leave it, please leave it. Yeah.
And maybe if you do an upper endoscopy, you may convince the patient that there is nothing to take it for. Sometimes they feel that it's they have a problem in the gut and they need to take it, but when they find out that there's nothing actually, so they may start to convince themselves not to take it. ساعات هم يعني مصدقين فيه قوي يعني.
I see.
Yes. Yeah. Okay. Dr. Ramadan Arafa is raising his hand. Please, Dr. Ramadan, please unmute yourself. Wants to comment.
السلام عليكم.
وعليكم السلام.
سؤالي لأستاذنا الدكتور صبحي والأستاذنا الدكتورة مي. Bilirubin induced nephropathy. Any solution for that? We face these cases for an advanced liver disease. And usually it doesn't resolve with dialysis.
Yeah. Dr. May?
Yes, we see those patients. Yes, it causes an AKI, some form of AKI as well. It causes acute tubular injury as well. And yes, we resolve to dialysis. And مشكلة طبعا, if this is an end-stage liver patient and you have an increase in bilirubin and you don't have much to do about it, this is a big problem. I am not sure if رأيك دكتور صبحي حضرتك.
I think let us take a look for all variables in a patient like this. It is not only the bilirubin which will damage the renal tubule, but there are additional factors. We can play with this additional factor. For example, if he is hypoalbuminemic, I will improve his serum albumin to improve the renal hemodynamic. If he is hypotensive, I have to improve his blood pressure to assure good kidney perfusion. Also, if I can decrease, if he's taking a diuretic, if I can stop or decrease this diuretic to decrease the load on the kidney. Number 3, if we can do hydration or alkalinization of urine. Alkalinization of urine can be of help. Any factor which is nephrotoxic, I have to avoid it. So,
I'm not sure if the transjugular approach can be of help.
Tips, you mean?
Tips, yes.
Tips.
So,
Tips will play on if there is a tense ascites.
yes.
It will improve renal hemodynamics through this way. But morbidity will be very high in a jaundice patient like this. I think, as I said, this story to improve serum albumin, improve blood pressure, if possible hydration, alkalinization of urine, giving antioxidant as acetylcysteine, and of course, treating the liver condition. This is all what we have in our hand.
We know the problem is exactly we are playing with what we have in our hands, but we know that the real treatment is liver transplantation.
Of course, yeah, of course.
Hepatorenal syndrome. If we have this option, we can start prepare for it earlier than to leave the patient to reach an end-stage liver, and then we just نقعد نلصم فيه يعني.
What about the liver dialysis?
Yes.
Yeah, it can help to remove this bilirubin.
Yes.
If we have a reversible hepatic condition, so or the patient is candidate for liver transplant.
Exactly, because if not, again, we'll be in a situation.
Yes.
In acute conditions and in rigid transplantation. Mars.
Yeah.
Mars.
Okay. We have no more questions and no more comment. Professor Sobh and Professor May.
Yeah. I would like to again express my thanks for Dr. Yasser and of course Dr. May for this great lecture and for our colleague and audience for their participation and raising these questions.
Very good questions, really.
Yeah.
Okay.
Thank you very much, Professor Sobh, and thank you, Yasser, for your effort. Really, you really choose good subjects. Thank you very much. Thank you.
Thank you, Professor Sobh.
خفيفة النهارده خفيفة.
And to the point. This is very impressive. Thank you for this very interesting lecture and to the point and very light and to the point lecture. Thank you, Professor Sobh, for leading this meeting, and thank you for all sharing professors and Professor Tariq Tantawi, Dr. Roman Al-Dib, Professor Aita, Dr. Ayman Rifai, all were with us today and were sharing us. And thank you especially, as Professor Sobh said, for all our audiences who shared actively in this session by their active questions and active interactions. Excuse me to close and this session and announce about the coming session about the use of CRRT, and excuse me to be by me this time to see this lecture, and see you next Wednesday, inshallah, CRRT user guide, and thank you very much.
Thank you.
Assalamu alaikum.
Thank you all.